All right, let's jump right in. Today, we're going to put on our clinical detective hats and solve a really fascinating puzzle, renal tubular acidosis, or RTA for short. We are going to break down exactly what it is, and more importantly, how you can tell the different types apart. You know, our bodies are in this constant, really delicate balancing act, especially when it comes to acid. And our kidneys? They're the master chemists in charge of keeping everything just right. But what happens when that system breaks down? What happens when the kidneys fail their most important acid test? Well, that's where renal tubular acidosis comes into the picture. At its core, RTA is just a group of disorders where these tiny tubes in the kidney, the tubules, can't handle acid the way they're supposed to. And when that happens, acid builds up in the blood. This creates a specific condition we call a normal anion gap metabolic acidosis. And that right there is the central problem we're going to unpack today.
First up, we've got type 1, or distal RTA. Now, the name itself gives us our first big clue. The problem is in the distal, or the far end of the kidney tubule. And the main issue? It's simple. The kidney just can't get rid of acid.
So, let's dig into the nitty-gritty. Deep inside that distal tubule, there are these special cells called alpha intercalated cells. You can think of them like tiny little pumps, and their one job is to push hydrogen ions, which is really our acid, out of the blood and into the urine to be flushed away. In type 1 RTA, that pump is broken. Plain and simple.
So if we're the detectives, what clues are we looking for? Well, there are two huge ones that just scream type 1. First, these patients have low potassium in their blood, hypokalemia. And second, and this is the real giveaway, their urine is alkaline. It's not acidic, because that broken pump can't push the acid out.
And that leads us to the single most important number you need to know for type 1. The urine pH is going to be stubbornly high, always greater than 5.5. Think about that. The blood is full of acid. It's screaming for help, but the kidney can't make the urine acidic. That mismatch is the smoking gun for type 1 RTA.
Now, this problem has some serious long-term consequences. Because the urine is always alkaline, it creates the perfect environment for calcium phosphate kidney stones to form. On top of that, the body gets desperate and starts pulling alkaline buffers from the bones to fight the acid in the blood, which puts patients at risk for things like rickets or osteoporosis.
So what causes this mess in the first place? Well, it's often linked to autoimmune diseases where the body is kind of attacking itself. Think Sjögren syndrome, rheumatoid arthritis, or lupus. But certain medications can do it too, like the antifungal amphotericin B, which can directly damage those critical pump cells. Okay, let's move on to our next case. Type 2 RTA, the proximal problem. Right away, you see the location is shifted. We're now in the proximal, or the early part of the tubule, and the problem is totally different. It's not about getting rid of acid, it's about failing to hold on to something precious, bicarbonate.
The core defect here is actually pretty straightforward. Bicarbonate is our body's #1 acid buffer. The proximal tubule is supposed to grab about 85% of it back from the urine. But in type 2, that process just fails. It's like trying to carry water in a bucket with a giant hole in it. You just keep losing all this precious bicarb in the urine.
Now, the clues for type 2 can be a little bit trickier. Just like type 1, patients have low potassium. But here's the twist. The urine pH is variable. So why is that? Well, once the bicarb level in the blood gets super low, what little is left can actually be reabsorbed, and that allows the urine to become acidic again. This type is also frequently associated with bone problems, especially hypophosphatemic rickets.
The classic cause you'll hear about for type 2 RTA is something called Fanconi syndrome, which is basically a widespread defect in that whole proximal tubule. But other things can cause it too, like multiple myeloma, heavy metal poisoning, or even certain drugs like the diuretic acetazolamide.
Okay, let's hit pause for a second. We've just seen that type 1 and type 2 are both defined by low potassium. But what if the potassium is high? This single crucial difference, that's the key that unlocks our third and final type of RTA. And that key difference, high potassium, brings us to our final suspect, type 4 RTA. This one is all about a problem with a hormone called aldosterone. In fact, it's so defined by high potassium that we often just call it hyperkalemic RTA. The name says it all. So the whole story here revolves around the hormone aldosterone. Its job is to tell the kidneys, hey, get rid of potassium and get rid of hydrogen ions. In type 4, you either don't have enough aldosterone or your kidneys just aren't listening to its message. Either way, the result is the same. Potassium and acid start to build up in the blood. So the diagnostic clues here are basically the mirror image of type 1. The absolute defining feature is high serum potassium hyperkalemia. And because the tubules can still secrete some acid, the urine is actually acidic. That's right, the urine pH is low, less than 5.5. Now that might sound weird, right? The blood is acidic, the urine is acidic, so what's the problem? The key insight is that the kidneys just aren't excreting enough total acid to fix the problem. This is mainly because the high potassium itself messes with ammonia production, and ammonia is absolutely essential for the kidney to package up acid and get it out of the body.
So what causes this aldosterone issue? Well, a lack of aldosterone is a huge one. This is super common in patients with diabetic kidney disease. It can also be from Addison's disease or from really common medications like ACE inhibitors, ARBs, and even NSAIDs.
The other side of the coin is aldosterone resistance. This is where the hormone is there, but the kidney just ignores it. This can happen with drugs like potassium-sparing diuretics, the antibiotic TMP-SMX, or if there's a physical blockage in the urinary tract.
All right, we've investigated all three of our suspects. Now it's time to bring them all together for the final showdown. Let's do a side-by-side comparison to really lock in these concepts for good.
This table right here is your cheat sheet. It boils everything down to 3 key features. First, the core defect. Type 1 can't secrete acid. Type 2 can't reabsorb bicarb, and Type 4 has that aldosterone problem. Next, serum potassium. This is your biggest clue. It's low in types 1 and 2, but high in type 4. And finally, urine pH. Stubbornly high in type 1, low in type 4, and kind of all over the place in type 2. Seriously, if you can remember this table, you can crack almost any RTA case that comes your way.
So, let's wrap up with one final test of your new detective skills. You've got a patient with hyperkalemia, that's high potassium, and a urine pH of 5.0. Based on everything we just covered, which type of RTA should immediately jump to the top of your list? The answer is right there just by connecting those 2 key clues.